sant yàlla.
looy xaar utal wéef nga scan nga fay te nag doo ci yokku dara.
Jar Oil Company stands tall as a trusted name in energy, keeping the Gambia moving with service stations across the country and a commitment to innovation and reliability. In Farafenni, Jar Group is reshaping our industrial landscape. The Jar Oil Cement Factory can produce up to 100,000 bags a day, reducing imports, creating jobs, and building a stronger Gambia brick by brick. And in the heart of the Central River region, Jar Farming Initiative is cultivating food security. With thousands of hectares under development and modern irrigation, Jar Farming is turning the Gambia's soil into abundance. Jar Group is more than a company. It is a vision of self-sufficiency, resilience, and progress. The Jar Group of companies, investing in industry, agriculture, and energy, building the Gambia's future today.
Africa is rising and business knows no borders. With Bloombank and PAPS, buying and selling across Africa is now effortless. Fast, secure, direct from your Bloombank account. One Africa, one connection, one heartbeat of opportunity, powered by Bloombank Africa. Bloombank Africa, in partnership with PAPS, connecting Africa, empowering you. Bloombank Africa, we make it happen.
It's 17 minutes past 8 o'clock in the morning on Monday, the 27th of April, 2026, and you're with Coffee Time with me, Peter Gomez. Now to a landmark in Gambian medicine. Dr. Kajali Camara has become the country's first home-trained consultant urologist, completing specialist training entirely within the Gambia and earning fellowship with the West African College of Surgeons. His achievement signals a new era in national healthcare, proof that Gambian institutions can now produce specialists of international standard. Well, beyond his clinical work at the Kanifing General Hospital, Dr. Camara will also be expected to mentor young doctors, ensuring that the country's medical future is firmly in Gambian hands. Well, he joins us now to reflect on his journey and what this milestone means for the nation. Dr. Camara, welcome to Coffee Time with Peter Gomez.
Yes, good morning.
Your first time in the studio, I suppose.
Yes, this is my first time here, and I'm pleased to have me here, Peter. Thank you so much. I am Dr. Kajali Camara, urologist. I'm from Kanifing General Hospital, and I was trained at Edward Francis Small Teaching Hospital. However, this journey started as far as 2003 when I enrolled into medical school, that's the University of the Gambia. So going through 7 years of intensive medical training, then graduated as a medical doctor. Then after graduation, I had a 2-year internship training as a house officer within the various specialties in Banjul, surgical department, internal medicine, obstetric and gynecology, and then pediatric. So from there, then I moved to Kanifing General Hospital as a medical officer. That was 2014. So I've been in Kanifing since 2014 until 2018 as a medical officer. Then during that period, I underwent different sort of trainings and different exams within the country. And then I went to USA for USAMLE. We call it United States Medical Certificate Licensing Exams. Then I came back to Kanifing, continue. During that period, I went to UK twice for their exam. We call it Royal College of Surgeons membership exams. So I did those exams, came back to Kanifing until 2018. That was when the postgraduate training initiated in Banjul. I was lucky to be the first group of doctors that went through that training. I think it was 2 of us in the general surgery. We have other doctors in other specialties. So that took about 3 to 4 years, going through various rotations within the surgical disciplines. And some of those are available within the country, and some we have to travel to fulfill the requirement for the program. And on completion of that, we went to Ghana to do the exam that is called the West African College of Surgeons membership exam. So after passing that exam, I become a specialist in surgery. Then I specialized in urology. Probably we'll come to that later. So that took another 4 years with an internship training within various subunits of urology. You know, if you say urology is just a bag of specialties, there are different subunits. We have a female urologist, we have andrology that deals with fertility, we have a constructive urology that deals with surgery that has to do with trauma and things like that. We have an endoscopic urology that deals with minimal invasive surgeries. And we have a pediatric urology. So there are a lot of specialties. So you have to go through that rotations. So I did that within the Gambia here and Senegal, one of the major hospital or biggest hospital in Senegal called Hospital General de Idriss Pouye, or some will call it Hospital General of Grand Yoff. Okay. Yeah. So actually my training started from there because then the Gambia was not accredited. Mm-hmm. So I was doing my rotation within Senegal and the Gambia, going forth and coming, until the last year I completed my rotation. Then this year I went for the exams in Ghana. And then thankfully we passed the exam, then become a fellow of West African College of Surgeons.
Congratulations.
Thanh you so much.
I know the chief medical doctor would love you to go back to...
that's his wish.
TH. But I said, we people in Serekunda, we need
doctors as well. Oh yes. Carnegie will never grant that. Yeah. They won't.
Yeah. Why did you choose the urology path?
Yes, this is a very important question. Actually, when I had interest in surgery, so it was a surprise to most of my senior colleagues because of the passion I have for general surgery. But after completing general surgery, it was a difficult decision to make because I looked around. Then there was only one urologist in the whole country, that is Dr. Abubakar Jah, who is my mentor and is a friend, very close friend to me and my family. So he was the only one. So we have a lot of patients coming to Banjul with their urine bag, their catheter, because they can't pass urine. Yeah. So I looked around and said, okay, the general surgery, there are some few consultants. We have at least 2 or 3.
One urologist for the whole country.
Exactly.
Whereas maybe every other doctor is a gynecologist.
Exactly. So I said, I think I should go for urology. And then Dr. Yao was actually interested in that. He kept telling me, come to urology. I said, okay, I'll think about it. But I had a lot of passion for general surgery. So when I looked around, I said, okay, I think I should go for urology. I consulted a few people, including Dr. Bite, who is a very close friend of mine, Dr. Marina. Then I finally went for urology. And then I think that was the best decision in my life. Because now, I said a few years ago, we have a lot of patients countrywide. Mm-hmm. But now you go to the urology unit, you don't see patients with catheter for that so long. So that means it was one of the best decisions that I made in my medical career.
Congratulations.
Thank you so much.
What were some of the biggest challenges you faced training locally, and how did you manage to overcome them?
So actually, in a resource-setting country like Gambia here, you'll have a lot of challenges. My first challenge was when I made the decision that I want to do urology, the country was not accredited for training. If I say accredited, it's not recognized. Medical training has 2 parts. One is undergraduate. You have 7 years, become a doctor. Then you need to go for more training to become a specialist. That can take you 6 or 7 years more.
Oh, wow.
Yes. Okay. So when
people say doctors earn a lot, well, they
should
work hard.
They should.
First and
they
foremost,
should.
Yes.
So now the first challenge was our hospital is not recognized. So then the postgraduate office...
So it can give the training, it can have qualified personnel.
Yeah.
They do the training, but because they are not accredited,
exactly,
they
can't.
The qualification will not be recognized.
Exactly. So it has to be accredited by West African College of Surgeons. If you say West African College of Surgeons, it's not one body. It's a body actually, but include lot of countries, including the Gambia, Senegal, Guinea-Conakry, Mali, Ivory Coast, Ghana, Nigeria, Sierra Leone, Liberia. So there are a lot of West African countries.
Both Francophone and
Anglophone, yes. Okay. So, and then Nigeria alone, you have more than 100 universities under this college. So they have to come to your university or your hospital and then qualify that, okay, this hospital can train. And even they give you a certificate to train, usually they will usually give you 2 years. And they come again and make sure that the standards are there. If the standards are there, they can give you another 4 years. Or they can just give you partial accreditation. It's okay, we are giving you partial accreditation, which means you can train doctors in these particular subspecialties, but they have to go outside for more training. Okay. So then the hospital was not accredited. So that was one of the biggest challenges. And I want to move. I don't want to delay. So what happened was, I found out that Senegal, their hospital is accredited. That's Grand Yoff. I said, okay, I think I'll start from there. So that created another challenge because Senegal is a francophone, and then now I don't speak French. So I say, okay, now what I will do, I just went there. Actually, I went with Dr. Ja. So I definitely am so proud that he led us throughout this training. I'm so proud of him, actually. So he drove me, myself and my wife. So when we went there, the Senegalese were so happy. So my wife is a doctor too. Yes. So he told her, okay, you came for one.
Usually that's what happens.
Exactly.
Doctors marry among themselves.
Exactly. So he said, okay, you came for one place, but I'm going to give you 2 spots, you and your wife. So my wife was not so interested. He's actually living in UK, sorry. Okay. So then I started my training. So the French was an issue. That was the biggest challenge. But then thank God, our local language, Gambia and Senegal is almost the same. So here and there, I will use those local language. Exactly. Yes. Yeah, they keep telling me Nanga definitely because of
they make fun of us.
Exactly. Yeah. So, but surgical training is more of hands-on than any other thing. So I was more in the theater to have more hands-on. Okay. When you come to the writing and stuff like, I give it to the younger doctors to do that. Yeah, that was one of the challenges. Until later, I think 2 years ago, when the hospital got accredited, then I moved on. But within that, I usually come to Gambia because we have more cases as there's only one urologist. So when I go to Senegal for a few times, I'll come to Gambia to have more surgeries, have impact. Then I was going there. So this is one of the advantage of local training. So if I was being trained in UK, I would not have had that opportunity. Yeah. And the Gambian would not have benefited from those procedures. Sure. So that was what was happening until when we have our hospital accredited. Then the support was there. Then things become fine. Until I finish all my rotation. So then I have to go to Ghana, and then
you spoke about support. Can you be a bit more detailed? How much support were you getting from the hospital, from government while you were training outside?
Yes. Actually, I would say I am very lucky. Probably because we are the first batch. One, I have all the support from my family. I need to thank them for that. But the most importantly, Carnifing General Hospital was very, very supportive.
How?
One, I had my full salary since 2018 up to date. And they've never complained.
You were spending your time mostly outside.
Outside, I was working at AFSTH. In fact, most people at AFSTH, they thought I was being paid by AFSTH. So here and there, I'll go to Carnif when they have some surgeries or when their surgeons are out of country or key ones are on holiday. I'll just go and operate there. So I would love to thank them very, very well, for that support. Then the hospital, Edward Francis Small Teaching Hospital, was also very supportive, even though I consider myself as foreigners, as Peter will call me sometimes. They were actually supportive. During my travel to Ghana, they are the one who paid my trip, and they've done that during my membership and also during the fellowship also. And of course, even allowing me to touch their patient is a support to me. But I think the biggest support comes from the Ministry of Health because, there was no postgraduate training then. When we had the university from the former regime, people would finish their medical school and then transited. Then you just become a general doctor until when this postgraduate program started. So this started around 2018. And when it started, there were a lot of doubts. People would think, okay, this cannot work here and there. BT and some other doctors like Dr. Keita were very supportive, Dr. Marina. So we initiated. Later we have Professor Yankuba Kasama who came in, and now he's the coordinator. So ministry support through the World Bank Fund was very, very helpful. That's what I was using going to Senegal for my accommodation and all of that. Yeah, so that was very, very helpful. And then, of course, my other colleagues, Dr. Jar, Dr. Robert, they were all supportive, actually, in terms of training. Yeah.
You and your two other colleagues, you are the first, as I have just been saying, to reach this milestone entirely at home.
Yes.
What does this say about the capacity of the Gambia to train its own?
Yes, it's myself and my two other colleagues who are very hardworking colleagues, Dr. Ablai Ba.
I should say in the next 2 Mondays they'll both be here.
Yes.
Somehow Dr. Bite has talked me into spending the next 3 Mondays talking to doctors.
Yeah, I know, that's great. So Dr. Ablai Ba, who has specialized in pediatric surgery, and Dr. Fatumata Jajusi specialized in obstetric and gynecology. So I would say this is actually a big achievement, one for us, but more importantly for the country. Yes. Because I can say, as I said, 20 years ago, there were only one urologist in this country, and that meant a lot. So what happened was some urology countries will be operated by a general surgeon. Because if you're a general surgeon, you can do some urology procedures, okay? And the obstetric gynecology, then they were none, or they were just foreigners.
Yeah. But if you just the question is, what does this say about the capacity of our institutions?
Yes.
Medically speaking.
Yes, so I think I would say that this is going to build the human resource gap that we have been facing throughout. And then it's going to encourage a lot of young ones coming up, okay? And then because, people have a belief West African college is very, very difficult because we have Nigerians there. So people will go for exam 3, 4, 5 times. They will not pass. So I think this is a manifestation that then there is a lot of improvement in the health. And then I will tell you, in the coming years or even in the coming months, you have more specialists. We'll expect more urologists in the coming months, and in the coming years, we have other specialties. So this means there is a lot of things happening within the health sectors that people are not aware of. So, and this is the thing we definitely need to embrace.
And that's why we are pleased to have you here.
Yes.
Now, for patients,
yes.
What difference does it make to have a home-based, home-trained consultant urologist available?
Yes, so this has a lot, it's going to change a lot of things. One, the long queue that patient will be waiting to have surgery will reduce. And the number of people going out of Senegal will absolutely reduce. Then during my time in Senegal...
Maybe not just Senegal, maybe people...
Exactly, yes, Turkey and India,
Exactly.
Yeah, so it will definitely reduce.
Yeah.
When I came on Thursday, and 2 days later, I went to Bansang. I operated on 2 patients.
Really?
Yes. The moment I did my first surgery as a consultant in Bansang. So imagine, this is the benefit of the training.
True.
So those patients are supposed to come here and have their surgery because there is no other person who can do the surgery within those areas. Mm-hmm. So I went to Bansang. I did 2 surgeries. And these are one of the collaboration we want to have between Bansang and the other rural hospital, so that we could just go there once or twice in a month. So I think this is so impactful in the health system, in the hospital, and then the same thing will happen to pediatric surgery, gynecology, with the help of Fatmata and then Dr. Ablaiba.
Okay. Mm-hmm. So by talking to you, we are literally celebrating, the capacity of, medical sector to train specialist staff, but I'm sure gaps remain.
Yeah.
Now, what gaps remain, and what will it take, to strengthen the entire system?
Yes. So, you are right. There's still some more things that we need to do as a country or as a hospital. One is we need to have more equipment. You can be trained, have all the skill, but if you don't have all the right equipment, then it becomes a problem. Then that means the knowledge is there, and then the skill, as time goes on, if you are not applying it, you lose the skill.
True.
So we need to have that as a country, and I think we need to have more collaborations with other NGOs, and the private partnership, and even outside the country, we need to have more collaborations, because now the world is moving to more of minimally invasive surgery. So if you don't have those equipment, we will still be using the old traditional open surgery, and then if you travel outside the country, you will have a lot of challenges. So I think we need more support in our hospitals from the ministry, from the government, and of course from the public also.
Okay.
Yeah.
So in terms of equipment, where are we? Are we modern enough, or are we still doing the old traditional open surgery as you've just been explaining, rather than the minimal invasion?
Yes. So I think we have still got some limitation, but there's some improvement, especially in our unit, urology. We were lucky 2 years ago, we had some equipment from the Qatar government, and those are standard. And we have a modern theater, and it's one of the, in fact, it's the best theater in this country, I can say. That was sponsored by the FAB Foundation, the First Lady, and we have all the...
Where is the theater? Is it at
yes.
EFSTH or Canifing?
No, it's at EFSTH.
But it should come to Canifing General.
Yes, so this is my challenge.
You are not in EFSTH.
Exactly. So Canifing is a problem now in terms of urological practice because we don't have those equipment in Canifing. So if I have to go to Canifing, I will basically rely on the traditional all open surgeries, so we have to get some equipment for that. Otherwise, my plan would be I must have at least a day in Banjul to have use those equipment for minimal invasive surgery until we have our equipment in Canifing. But if you go to other units, yes, obstetric and gynecology, they also have some equipment, but as I said, we need more of those ones, and sometimes we have challenges when you get equipment worn off before you could get a replacement and things like that. Yeah.
At the beginning of the program, you did mention that urology is a wide area. It covers so many different areas. Maybe this is, the time now to go into the main ones.
Yes.
Just the main ones.
Yes.
Maybe not everything.
Yes.
You might not have time for everything.
Yes. So urology is very wide, actually. If you go to, because urology is surgical discipline that deals with urinary tract. It deals with the disease of the kidney, disease of the ureter, that is one of the pipe that connect the kidney to the bladder. It deals with disease of the bladder and disease of the prostate. And the urethra, that is the pipe that connect the bladder to outside. And also it deals with the male reproductive organ, the penis, the testes, and also with female female urinary system. And then sometimes there is a condition called vesico-vaginal fistula. That's a communication between the vagina and then the bladder. Usually females suffers from it when they have a difficulty in labor. So we also deal with that. So prostate is one of the major burden for men.
Yes.
And the prostate cancer.
Now you worry me.
I know, right? I know your age is advancing.
I'll come running to you to
exactly.
check my prostate whether everything is okay.
Exactly.
Yeah?
So
don't worry, Dr. Jad does that for me.
Exactly. Every man has a prostate. So as you grow up, it increases in size. So at the age of 40, you have about 20% risk of having prostate disease. And when you have 60 years, you have 60% risk of having prostate disease, such as BPH, prostate cancer, more specifically.
So how often should I be, going for checks?
Yes, so this is a very difficult, tough question because, going for screening has a criteria. We don't want everybody to just go for screening for it. Because if you do that, you will diagnose a lot of patients and you'll overtreat them. Because the good thing about...
Overtreat?
Yes, you'll overtreat them. Because the good thing about prostate is you can have a prostate cancer. We say you can die with it, but not die from it. That means you can be having indolent one. It doesn't cause any problem with you. You are doing your life fine. But now, if you are doing a proper screening, regular screening, and they pick up that disease, that now becomes a burden to you. Maybe this coffee time will even stop. You'll be thinking about that prostate cancer. And then if you have not checked for it, it won't have caused any problem for you.
Sure.
So now if you go to a doctor, you have
some people, you tell them, well, why don't you go to medical to know?
Exactly. So this is why we don't want to do general check. But if you have a family history of prostate cancer, especially at a younger age, less than somebody with prostate cancer around 50 years, if you have a family member of that, then people like that are at risk. We call it, you can do an individualized or opportunist screening. But we don't usually advise.
Unfortunately for some of us, our parents died without us knowing what killed them.
Exactly. Exactly. That is it. But if they die at advanced age, 70, 80, then we will know that, okay, probably it's not a genetic.
To the child,
yes.
The parent will always die old.
Exactly. Because you always see that. I agree. Definitely agree. So prostate cancer is very, very common. It's the second commonest cancer within male. In the country here, we believe is the most common cancer.
That's
what
I
we
was
believe.
told.
Yeah,
this
in
is
the
why
main.
when you say, second most, I was going to ask.
Globally.
Globally. Okay.
Yes. So
here
because
we are told prostate is number one.
Yes.
Yeah.
Yes, that's what we
That's
believe.
What scares the hell out of me every morning.
Exactly.
Why was I born a man? I shouldn't be born a man.
I know. But if you go to female, they will also talk about cervical cancer, breast cancer. Yes. So that is it. So that means with the good thing about the prostate cancer, you can die with it, not die from it.
Okay.
Yeah. So we don't want to do.
In other words,
screening.
you can have it without necessarily being killed by it.
Exactly.
Yeah.
So that is it. So it's so common. I mean, if you observe, you see a lot of elderly men.
That should calm a lot of men this morning.
Yeah, I know. It will.
Because people have prostate cancer, it won't kill you.
Yeah.
But you will go to the grave with it.
Yes, you can go to the grave with it. Yes, so this is why we don't encourage too much of screening, but because the psychology alone will cause a lot of trauma. And then if you screen everybody, I don't think our system or our health system is ready to treat all these people. So then everybody will come with prostate cancer. Exactly. Those who actually needed the treatment may not have all the attention that they should have. So you have to put attention to everybody. So this is why we don't screen for it. In some advanced or developed countries, actually they are doing screening because they have all the manpower, they have all the equipment to deal with it. Places like some other European countries. Mm-hmm.
Yeah.
What role do you see for technology research and innovation in strengthening specialist training?
Yes. So yes, technology is actually very, very important. Because one. Now when I was preparing for my program, even my exams, I don't need to go out to Senegal sometimes. You do my program through online. You can do your discussion with your supervisors, your research, so you don't need to go outside. So that was very helpful. It does more cost effective compared to going to Senegal every now and then, even though I have the support. Sometimes when I was traveling to Senegal, the World Bank PCU, that is Project Coordinating Unit, I need to thank them a lot. They were so helpful. They were so helpful to me. People like Satang and Sagara, Fatunjai, they were all so helpful. I'm so grateful to them. So, if you get a ticket, I was telling, okay, don't get me a ticket because going to Senegal, you stop at Mbour. I prefer going through the bus, actually, So, but then with the technology.
You use the GTSC bus?
Yes, I use the GTSC bus. We struggle. In Senegal, sometimes, when I was in Senegal, the traffic is sometimes so difficult. Yeah. I sometimes get into this motorbicycle. Just to divert the traffic.
Jakarta.
Oh yes, we've done that. We've done that a lot of time. Yes, the struggle was actually real.
Wow.
But then it's just a passion. What you want to achieve, you need to achieve
Absolutely.
it. We had opportunities. When I finished medical school, I went to USA. I did USMLE. I have the opportunity to do some other specialties that are non-surgical. But my passion was for surgery. I did not stay there. I came back. That was how I then maneuvered to the UK program, do some exam, then that opened ways for me to do the West African program. So it's just the passion. If you have the passion, then it will take you anything, So we use a motorbicycle to maneuver the traffic or go to the hospital. I'm sure Dr. Bao was in Ghana. If he tells you his stories, they'll be more interesting.
Whether it's him first or the lady next.
Yes.
Next week we will hear their story.
Sure.
How do you think your qualification and your insistence on going back to Kanifing General Hospital will benefit Kanifing General Hospital both in terms of personnel and equipment?
Well, that's actually absolutely is going to cause a lot of impact because recently we don't have any urology in Kanifing. Yeah, so we have somebody who's trying to help. He has interest in urology, Dr. Ansumana Sanya, and he's doing some more small procedures and then diagnosing, then sending patient to Rosto Banjo. So going to Banjo will minimize patient going to Kano will minimize patient going to Banjo, number one. Yes, so
most would come through Serekunda.
Most would come through Serekunda, yes. And we have only one Gambian consultant there, Dr. Mane, who's doing general surgery. So obviously I'm going to be the second one there. Obviously, in terms of patient benefits, going to cause a lot of impact. Number two, in terms of equipment, I was lucky, I think 2-3 years ago, I went for a training in vesicovaginal fistula in Zambia. So during that training, Gambia is sellable when you go outside.
Is it?
It's very sellable. I told her, okay, in my country we have only one urologist. Everybody was, wow. I told them all the problem we had. So they thought, okay, I think we can come to the Gambia.
They must have thought that every man is walking around with a catheter.
Exactly.
There's only one urologist.
Exactly. So they said, okay, I think we can have a collaboration with your hospital. Then they came here. They're from Netherlands, about 3 of them, urologists. So we had some tour within the hospital, and they were also interested in going to Bansa. So they came with this modern equipment, actually, into Carnifing. So we did some surgery last year, November. We did about 63 prostates that were operated, minimally invasive, not open, that were minimally invasive. That's an international standard. So those equipments are here, and those are millions of dollars.
Okay. Why would you operate a prostate? To make it smaller or what?
Yes. So the prostate actually, as I said, is just like a size of...
I'm interested in the prostate.
Yes, you should.
Okay. I'm 64.
Oh, then you should. Huh? You have 60% of our BPH. So prostate actually is like a size of a peanut. Or we say walnut. We don't have walnut here, so I'll describe it as a peanut.
Yes.
So it got bigger as you age, because what happened is that the testes produce hormone we call testosterone. So those testosterone will germinate this prostate to get bigger and bigger and bigger. So what happened? The urethra passed through that prostate. So as the prostate is getting bigger, it will compress on the urethra and it change your urine pattern. So some of them, now you started, there are different types of management when they come, depending on, we said, how it affects their quality of life. Like if you come, I say, okay, I can't complete my radio program. I'm always going to the toilet and to pass urine. It affects yes, okay, this is affecting your quality of life. Or I can't go to church. Or I can't go to the mosque. So when it affects their quality of life, initially we start medical management. We give them medication. Some will do well with it, but some will have we call acute urinary retention. They will just go somewhere one day and they can't pass urine, or they will have recurrent infection, or they will have stones in their bladder, in their kidney. So when they have that, the remaining urine in the bladder...
Stone as in
stone? Stones as in stone. Really? Yeah. Let me give you a description. If you put the water in a jar, like this local jar, so sometimes at the bottom of the jar, you feel like you see some form of
whitish
things and things like chalk, stuff like that.
Yeah.
So the same thing happens. When the urine stays in the bladder, it's not coming out, then it got stone formation, and then this happen when you have a prostate or stricture, things like that. So if you don't operate on them, this remaining urine will flush back to the urethra, to the kidney, and they could have a kidney damage. Yes, so you need to make sure you operate so that they could able to pass urine if medication fail. So this operation, there are 2 types. You can do an open, make an incision on the abdomen, remove the prostate, but you can do a minimally invasive, where you don't need any open surgery. There are cameras that you go through the urethra, through the penis, and then you peel off the prostate. When you peel off the prostate, then he will be able to pass urine. Okay. So the patient will admit for only 2 days and go home without a pipe.
Okay.
Yeah.
So the prostate is supposed to have some controlling effect on the flow of urine, I suppose.
Yes.
So what happens when you take it off?
No. Yes. So when you take it off, nothing happens actually if you do the procedure right. Even though every surgery has its own complication, if you don't remove the prostate the way it's supposed to remove, that means if you don't respect the boundaries that you're supposed to respect when you are resecting, they may have some issues of incontinence, unable to control urine and things like that. But some of them will settle as time goes on. Yeah. But the prostate main function is for reproduction.
Okay.
Yeah, because the sperm, it has some liquid that it secretes that get into the sperm, and it helps in the reproduction. So this is why sometimes it's challenging if you want to operate on some patient. It's okay, because you need to tell them that if you remove this prostate, it may affect your reproduction. You may not able to have the child. But thank God it happens at the
but when you're 60s, you don't start talking about it.
Mind you, some Gambians get married when they're 70. We do have those challenges. People don't want to operate it because they want to have more kids and here and there. But but then as soon as they got more burden with the symptoms of the prostate, they will have to subdue it for surgery.
It off.
Exactly. Just take it off.
Exactly.
No more children.
Exactly. Just get rid of it.
Yeah, exactly.
All right. Well, listen, it's good to have you, but you had to travel thousands of miles, spend years outside the country. Just acquiring the knowledge that you have.
Yes.
Now, how about knowledge transfer? I spoke about the need, for mentoring.
Yes.
Have you started mentoring?
Oh yes. We've started that actually because I am actually a lecturer too within the University of the Gambia. Yes, for the past 3-4 years now.
Earning a consultant urologist salary and a lecturer salary. Huh?
Lecturer salaries are just...
I chose the wrong profession.
No way. Actually, medical program is like, for me, this achievement is the beginning of the learning. You need to learn. You need to continue learning. If you want to practice more efficiently, you need to continue learning. And then you need to retain the knowledge you gain. And retaining that includes teaching others.
True.
Yeah, you need to do more teaching. You need to do more publication.
As you teach, you are reminding yourself of what
Exactly. So that's the best way to retain information, and that's the best way to acquire more knowledge, to acquire more development. So that's one of the reasons why I still don't want to leave EFSTH completely, because this is that's a teaching hospital.
Well, we will make sure you leave EFSTH completely. and really, supplant yourself firmly.
I know. But kind of thing, we have a very, very, very intellectual administration, the CEO and then the administrator Babakar Sen. They are very understanding and they know this whole journey. They were aware of it. No. They were there from the beginning.
I don't want them to be understanding. They need to be possessive.
Yes,
they should
definitely.
They should take back theirs.
Oh yes,
this
is definitely theirs, because even in Banjul, I always brag about, okay, I'm going back to Kanvi. I'm not your staff. I'm the staff of Kanvi Hospital.
Remind Dr. Bite always.
Exactly. I always reminded him about that. Yes, so but then to continue the education, maybe I will not just need some few time here and there to go to Banjul and do the teaching with the medical student, interact with medical students. Maybe in the near future, we may even have medical students come to the canopy, for our expertise. Absolutely. To have interaction.
Absolutely. Yeah. I'm just looking at the time. It's 8:52. Wow. Time flies when you're really enjoying this conversation. Yeah. And if you could send just one message to Gambian youths considering medicine, what would that message be?
Wow. Well, I know, to me, I have a lot of passion in medicine, because it's not about money. There is no money. But it's about
There's no money in medicine.
No, there is no money.
You know what doctors
BJ will agree with that, I'm sure. But, the thing is, in this life, to me, it's about what you give to people. Every single day, you make somebody feel happy. During this deliberation, I was going through comments on the Facebook, and I've seen a lot of people talking about things. Oh, this man helped me here and there, which I was not even aware of. Can you imagine somebody come to the hospital with a catheter, or not with a catheter, with a retention, cannot pass urine? Just a simple procedure, 2-minute procedure. And then how that person is going to be
that short?
Yeah, 2 minutes.
Oh, wow.
You just need to put a pipe in, and then he will pass urine. You see how relieving that is. Yeah. So that alone is enough for me. So I think people need to look at medical discipline. Forget about the years, 20 years, 10 years, 30 years. No. To me, medical practice, the teaching is throughout your life. As far as you are a doctor, you'll be learning every day. So just forget about that. It's very fast. 7 years is just 7 days to me, and then the first 4 years is what is complex, but then after then you'll be in the clinical, you feel like you're a doctor. So I think we need more doctors. And then most importantly, we need to make sure that after our training, we stay in the country. This is very, very important. That is the most important. If you are trained, we use the country's research on you, people have high hope in you, and at the end of the day, you leave. That is very disappointing. So I think we should train, but then the most importantly, people should retain and make sure that you train more people. So imagine Dr. Jao was in UK. If he never come here, what would have happened? The 2.7 million people relying on one urology. If that was not available, that was going to be very catastrophic to the country.
Absolutely.
Yes.
Dr. Camara, thank you so very much.
Thank you so much,
I really
Peter.
enjoyed your company.
Thank you so much.
I can assure you, this is not your last visit.
Thank you. No problem. I'm always available.
Dr.
sant yàlla. Looy xaar utal Wave nga scan nga fay te nag doo ci yokk dara.
Jar Oil Company stands tall as a trusted name in energy, keeping the Gambia moving with service stations across the country and a commitment to innovation and reliability. In Farafenni, Jar Group is reshaping our industrial landscape. The Jar Oil Cement Factory can produce up to 100,000 bags a day, reducing imports, creating jobs, and building a stronger Gambia brick by brick. And in the heart of the Central River region, Jar Farming Initiative is cultivating food security. With thousands of hectares under development and modern irrigation, Jar Farming is turning the Gambia's soil into abundance. Jar Group is more than a company. It is a vision of self-sufficiency, resilience, and progress. The Jar Group of companies, investing in industry, agriculture, and energy, building the Gambia's future today.
Africa is rising and business knows no borders. With Bloombank and PAPS, buying and selling across Africa is now effortless. Fast, secure, direct from your Bloombank account. One Africa, one connection, one heartbeat of opportunity, powered by Bloombank Africa. Bloombank Africa, in partnership with PAPS, connecting Africa, empowering you. Bloombank Africa, we make it happen.